Given, so can we start the recording, please? Also, can you please switch to the full screen mode? So can you go to the first slide, please? Kiran, sir, you will have to restart the recording, please. Yes. Good afternoon, everyone. Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is HIV-TB co-infection, case finding, management and prevention of tuberculosis. And the speaker is Dr. Anwar Parvez Sayed. Dr. Anwar Parvez Sayed is a public health specialist. He is an affiliated clinical associate professor at the Department of Global Health of the University of Washington and also a doctoral candidate in the Global Health Leadership Program. He is the director at iTech India and now working for WHO's Eastern Mediterranean Regional Office at Cairo, Egypt. We welcome you, sir, for today's session and request you to start the session.
Thank you, Shweta. 1 second. Okay, can you see the screen moving?
Yes, sir.
Okay, thank you. Okay, good afternoon, everyone. It's very nice to be here after a long time. So this topic, which is national guidelines session. So many of you might have attended the previous sessions, distance learning sessions on many of the topics which are under the national ART guidelines, which were released last couple of years before now in 2021. And today's NDLS is on HIV-TB co-infection case finding. In fact, I think in the last month itself, there was an NDLS on the same topic, and the same presentation was used in that NDLS. So my job here is, again, this is a long presentation, and in fact, all of it has been taken from the National ART Guidelines from Chapter 2.8 of HIV-TB co-infection. So for many of you, it will be kind of a revision session. And if at all there is anyone who has not seen these slides before, and if you have any questions, please feel free to ask. Another disclaimer is, as I mentioned, that there are almost like 60 slides in this, and it is a text-heavy presentation. So I'll not be reading all the text. I'll try to explain what the concepts and what it means to be like, even definitions. Those are text-heavy. So I will not go in details of like reading the slides as such. I'll try to just skim through a few slides. Okay, so getting back to the topic, so this is about HIV-TB co-infection and its presentation. And those who are working in the ART center since long time have, I'm sure you have listened to these, read about these, and practiced HIV-TB co-infected patient treatment management so many times now. So, but the guidelines kept on changing over a period of time, and also these concepts, they were like, some of the concepts are new, and that's why all these repetitions and revisions are helpful. So what we will do is we will do the introduction of HIV-TB co-infection, how these diseases, they interact with each other. And we'll see the general principles of management of HIV-TB co-infected patients. Something about the toxicity of anti-TB medications, how they interact with ART, what need to be done, and also in children living with HIV, what need to be done about the management of such cases. So as I mentioned, all of it has been taken from the National ART guidelines, which was released by NACO in 2021. Okay, we have been told like many times, and also we have experienced that TB is the most common opportunistic infection in India in HIV positive patients. So those who are in this 18 years, like 15 to 21 age group, these patients are very likely to develop active TB than those who are not HIV positive. So as Indians, I think most of us, like more than almost 50% of us, will be infected with tuberculosis, but many of us do not develop tuberculosis disease as such. But if someone is HIV positive, it is easy for that person to develop TB disease. And presence of TB disease itself, it will accelerate the progression of HIV or multiplication of HIV. And many people die because of TB who are PLHIV, and the estimated number of deaths was 71,000 in 2019. So this is just to explain further about the interaction. We know that in HIV, immunity declines, and there is a severe immune suppression if people are not started on ART. CD4 goes down, which represents the cell-mediated immunity. So with decreased cell-mediated immunity, and also the other interferon gamma, for example, is reduced, this becomes a perfect opportunity for the hidden TB infection to manifest itself as a TB disease. So Mycobacterium tuberculosis, which was a latent TB infection sitting inside our bodies, so that will come out as a TB disease, and it becomes or it presents itself clinically. So the and then macrophages, cytokines production will increase, and that will help, especially interleukin-1, 6, and TNF alpha, TNF, and because of that, viral replication is further enhances. So there will be much of viral replication, which causes AIDS, which causes again immune suppression. Again, the cycle continues. So this is also the reason why the reinfection rates are also common. So there are general like few principles in HIV-TB co-infected patients for management. One is we have to actually look for tuberculosis disease in people living with HIV. It is called as intensified case finding, which means that we proactively ask them about the symptoms of TB when they come for clinical visits to the ART centers, or for that matter, any other facility. And if they are found to be symptomatic or positive for any of the symptoms from this complex, then we send them for investigations to diagnose them if they have any active TB disease. And if they are not on ART, early initiation of ART is one of the most important principles, because it helps in managing the present TB, as well as it prevents the further TB resurgence in future. And lastly is about the co-termoxazole prophylaxis, because we assume here that people who are having active TB will be having lesser immunity, which will prone them for other opportunistic infections, especially PCP. And to prevent that, we give co-termoxazole prophylaxis to all patients who are HIV-TB co-infected. So we have seen this flowchart like so many times by now. So when we say that we look for symptoms of TB in these patients, so we talk about this 4-symptom complex. In adults, current cough, fever, weight loss, and night sweats. In children, it is current cough, fever, poor weight gain, and history of contact with TB case. So if the patient who is visiting an ART center has, or any other facility for that matter, has any of these symptoms, then we try to we investigate those patients for presence of active TB disease. And if we diagnose active TB disease, we will treat them with anti-TB medications. If it is not there, then we will consider those patients for the isoniazid preventive therapy or IPT if there are no contraindications to isoniazid. If there is any other infection we come across or we diagnose, for example, pneumonia, and we treat for that infection. And if the patient does not have any TB symptoms, then we'll definitely consider those patients for isoniazid preventive therapy. It's a one-time affair, actually. IPT we give once in a lifetime to a PLHIV who does not show any signs and symptoms of TB. Means if they do not have active TB and if they do not have contraindications to IPT, we give them IPT for 6 months. So that's as per the national guidelines of HIV care and treatment in India. So for diagnosis, then so these patients who show symptoms of TB are called as presumptive TB cases because we are yet to confirm them. So when we send them for investigation, the most important test we do is CBNAT, cartridge-based nucleic acid amplification test, which is also called as gene expert, or TrueNAT, that is also recommended by WHO. This is very similar case. Again, differences between the sensitivity and specificity. So if the NAT test is positive, which means if we diagnose Mycobacterium tuberculosis, and if it is resistant to rifampicin, which is the most important anti-TB drug, then these patients need to be sent to DRTB center, drug-resistant TB center. They should not be treated at ART centers. And when we send them there, they do the first-line LPA, and which means they test for resistance to INH and also resistance to other anti-TB drugs through second-line LPA and liquid cultures. And then they decide on treatment at that center. And if rifampicin is sensitive, then we start ATT, anti-TB treatment in the ART center itself. And we start ART in those patients. But simultaneously, we also send the sample for first-line LPA for detection of INH resistance. And because results will come a bit later, and if we diagnose INH resistance in these patients, we send again these patients to DRTB centers for further investigation and management. And if later INH resistance is not there, which means the patient is sensitive to rifampicin and INH both, so patient will continue on the same anti-TB treatment at the ART center itself along with the ART. So, and in the beginning, if we see the CBNAT is negative in these patients, then we look for other supportive evidence for active TB, like X-ray, sonography, and maybe clinical decision of treating medical officer. If we think that patient has TB in the opinion of the medical officer treating, that is called as clinically diagnosed TB, and then we decide on treatment based on our clinical decision. So these are definitions. These are programmatic definitions. Again, I'll not read through all definitions, but I'll just try to mention the meaning of these words, like microbacterial or microbiological confirmation. So based on microbiological confirmation, there are two types of TB, that is microbiologically confirmed or clinically diagnosed. So microbiologically confirmed means patient's gene expert is positive or CBNAT is positive for tuberculosis, and clinically diagnosed means a patient whose gene expert is negative or not tested, but their X-ray shows signs and symptoms of TB, or maybe sonography shows signs and symptoms of TB, or in other clinical is again based on clinical decision of the medical officer to decide whether it is whether the patient is having TB or not. Then based on its site, it can be divided as pulmonary or extrapulmonary TB. So pulmonary, obviously, as name suggests, it is TB in the lungs. But one thing to remember here is that miliary TB, which is a kind of hematogenous dissemination of TB bacilli, and what we see in the lungs is miliary presentation. So because we see that in the lung, we call it as pulmonary TB. And as per TB programmatic definition, if a patient has pulmonary and extrapulmonary TB, we categorize those patients as having pulmonary TB. So this is, I think, one point to remember because people usually get confused here. And then extrapulmonary TB is any microbiologically confirmed or clinical diagnosed TB, which is outside the lungs is called as extrapulmonary. So TB of bones, lymph node, intestine, genitourinary tract, or meninges or brain or anything else other than lungs, it is called as extrapulmonary. So based on previous history of TB treatment, there are many categories under this. Any patient who has not been treated with anti-TB treatment in past or treated for less than 1 month is called as new TB case. So this can be in private clinic, this can be in program or wherever. If the patient has taken anti-TB treatment for less than 1 month and now patient is microbiologically or is having TB, is called as a new case. And previously treated, anyone who has taken treatment for more than one will be called as previously treated TB case. And recurrent case means those patients who have completed TB treatment in past and now microbiologically confirmed TB. Treatment after failure in last or most recent TB episode, if there is a if the TB program has declared that patient as a failure, and that has been documented, and now patient is microbiologically confirmed TB case, is called as treatment after failure. Then treatment after loss to follow-up, declared loss to follow-up in the previous treatment, and now patient is having TB. And others means previously treated who have previously treated for TB but cannot be classified in any of the above categories. So just to summarize this part about classifications, it is important if we are working in the national program to categorize the patient in one of these categories whenever we make diagnosis of TB. So for a clinician treating in a private setup, which is not part of national program, suppose it is easy for that person to say it is a TB case or not. But for us who work in the national program, we will have to categorize the patient under one of these categories to say if the patient has TB, it is what type of TB, what is the, if it is pulmonary or extrapulmonary, if it is a new or previously treated or failure or whatever. So one of these categorization has to be done, and it is very important programmatically, because based on that, you will see that how you are, after completion of TB treatment, how you categorize the outcome of TB treatment is based on what you have defined in the beginning. And lastly, drug resistance is, we'll see about drug resistance in a minute or so. So drug sensitive TB is when TB bacillus, which is isolated, is susceptible to all first line anti-TB drugs. It is called as drug sensitive TB. Drug resistant TB is the bacillus which has been isolated is resistant to one or more anti-TB drugs. Now under DRTB, drug resistance TB, there can be multiple again types which will come later. But it can be resistant to one drug, which is called as monodrug resistance. Can be more than one drug, it is called as polydrug resistance. MDR-TB has a specific definition. So when a TB patient, or it is subset of drug-resistant TB, obviously, but bacilli are resistant, should be resistant to INH and rifampicin both, with or without resistance to other anti-TB drug resistance. So that is called as MDR-TB. But otherwise, if there are more than one drug resistant, it is called as polydrug resistant TB. Now, regimen for new and previously treated drug sensitive TB, that is the plain simple first line anti-TB treatment. It is for 6 months, 2 months of intensive phase and 4 months of continuation phase. And in 2 months, we give 4 drugs, INH, rifampicin, pyrazinamide, ethambutol. And for the next 4 months in continuation phase, we give 3 drugs, INH, rifampicin, and ethambutol. And we all who work in the RT center know that we have this fixed dose combination of all these medications available. And we decide the number of tablets given to the patient based on the weight of the patient. So these are the weight bands. There are 2 different weight bands we use in the program. And one is for adults and one is for pediatric patients. Now, whom do we call adult in TB program is those who are more than 18 years of age, and less than 18 years of age are called as pediatric patients. In the HIV program, it is 15 is the cutoff, which has not changed, I think, but please confirm that if I'm wrong. So this what I'm showing now is the weight band for adults, where you give these number indicates number of tablets, and you can see the fixed dose combinations and strength of medications in those tablets. So as the weight increases, we increase the dose, but it has to be more than 5 kg weight gain during the treatment. This is at the baseline. This is how we start the treatment. But during the treatment, if weight increases to more than 5 kgs, so it should be like it should cross more than 5 kgs on the treatment. And if the weight band changes, then we need to actually change the number of tablets which are given to the patients. And as these are fixed dose combination, which has more than like 4 or 3 drugs in it, a patient may be having side effects to one or more of medications. So if there are instances where you have to substitute that with another medications, then you'll have to give loose medications. We used to give streptomycin in past, but now in the first line, it was considered as first line, but now it is considered as second line. And some of these anti-TB drugs are hepatotoxic, and some which we use for OI treatment, like fluconazole, for example, is also hepatotoxic. So we need to be careful when we give it together. So for that, we need to monitor liver functions. So as a follow-up for first-line anti-TB, they come to the ERT center every month usually. So we do at least once monthly clinical follow-up of these patients. We look for their clinical presentation, weight gain, and maybe side effects or toxicities, or maybe like other comorbid conditions. Laboratory, we have to do at the end of CP, IP, this smear microscopy. We don't do CBNAT for follow-up. Reason being, because CBNAT can be positive, and even if there are dead bacilli in patients' sputum, because it's nucleic acid amplification test. So if it detects, even if it is a part of a DNA which is present in a dead bacilli. So that is why we just do sputum smear examination for follow-up, if it is and see if it is positive or negative. And also we do smear examination on the completion of treatment. About the adverse effect or side effects of anti-TB drugs, the INH, rifampicin, pyrazimide, ethambutol, most of the patients will not have these side effects. The common side effects like nausea, vomiting can be there, and which can be managed with antacids if the patient has any, or antiemetics if the patient has vomiting and all that. But some patients may present with other side effects which we need to be careful about. So INH can cause peripheral neuropathy, skin rash, hepatitis. INH, rifampicin, and pyrazinamide are hepatotoxic medications. So if patient is on these medications, you need to think about drug-induced hepatitis, and if there are any signs and symptoms, we need to investigate accordingly. Rifampicin can gain present there can be the side effects of abdominal pain, nausea, vomiting, hepatitis, cutaneous reactions. Pyrazinamide, arthralgia or GI problems, and ethambutol can have the serious retrobulbar neuritis, which has to be taken very seriously, and patient has to be stopped on treatment. There can be other rare side effects of these medications. And this actually slide summarizes the if patient presents with these symptoms, which can be the responsible drugs in those cases. So in and all, any TB medication can cause nausea, vomiting, or GI side effects, especially in the beginning. But once patients are accustomed to anti-TB drugs, they usually do okay on those drugs. And like I said in the previous slide, INH, rifampicin, and pyrazinamide are hepatotoxic, and if there is any jaundice or if there is continued GI symptoms, you should look for hepatic enzymes. And also there can be anemia or like tiredness, lethargy, which can be because of anemia, which can be because of INH, rifampicin, and pyrazinamide. There can be some serious skin reactions, which can be due to ethambutol, pyrazinamide, and streptomycin. Aminoglycosides, which we are not using so commonly these days, like amikacin, kanamycin, they can have ear toxicity, and there are some drugs, and also aminoglycoside may cause kidney toxicity, and along with streptomycin. Then INH can cause seizures, and also it can cause psychiatric disturbances in some patients. So whenever you see side effects in general, you can refer to these tables and see which drug is responsible. And because we are giving fixed dose combinations, you'll need individual drugs in such cases to find out which drug is exactly responsible and make changes accordingly, which may not be available at the ERT center. So you need to coordinate with the TB clinics to get those medications. Now, this is the most important drug, I guess, rifampicin, and in anti-TB treatment, and it may interact with the other drugs which we use for HIV positives, like protease inhibitors, NNRTIs, and also antifungal drugs. So rifampicin interacts with these a lot due to cytochrome P450 enzyme system activation. Both these drugs, they activate cytochrome P450 enzyme systems, and that's how they interact. And as a result of that, there won't be enough therapeutic levels of these drugs in the blood, and that's how patients they do fail the treatment. That is why patients who are on rifampicin-based anti-TB treatment, we don't give protease inhibitors in those patients, or nevirapine. We can give efavirenz because it is not affected to the same level. But again, the other drugs also may cause problems. So rifabutin is considered as an alternative, even though it also interacts, but the interaction is much lesser than rifampicin. And the common side effects of rifabutin also are like GI upset, rash, inflammation of eyes, and joint pain, and fever in some patients. One thing to be, I think, remembered is we need to ask patients to avoid wearing soft contact lenses, as they can become discolored, and avoid nevirapine treatment. Okay, so about explaining further more about rifampicin, rifabutin, and how they interact with ART. Like I said, NRTIs, they do not have any interaction with these drugs, and the dose of rifabutin is again 150 milligram once a day. Efavirenz, it doesn't have any interaction. It can be given safely. The problem is with nevirapine, which we are again not using that commonly in the national program these days. So there is a high risk of liver toxicity and also drug interaction. So we do not use them together. So protease inhibitors, we don't give with rifampicin, but we can give with rifabutin. Dolutegravir with rifampicin, if we are using dolutegravir, then we give an additional dose of dolutegravir to compensate for reduced level of DTG in those patients. And if we are giving along with raltegravir, then along with raltegravir, if we are giving rifampicin, we give that in the dose of 800 milligram twice a day. But in case of rifabutin, if we are giving to the patients, we give that as 400 milligram twice a day. I know rifabutin is not available these days in the ART centers, almost all of the ART centers and programs. But if we have to use rifampicin, this is how we use rifampicin along with these medications. Now, if the patient develops drug-induced hepatitis, this is how we try to manage those patients. First of all, there is a transient asymptomatic increase of liver transaminases, which occur during early weeks of treatment. It can happen in many patients, and we don't need to interrupt any treatment if the patient has symptoms of GI upset, like vomiting and jaundice. We can we can treat symptomatically those patients, but if it once worsens further, then we have to take the decision to discontinue anti-TB medications in those patients. So if there is a jaundice or any clinical feature suggestive of acute liver failure, then we must stop the drugs until the jaundice or hepatic symptoms are resolved. And it is we wait for 2 weeks usually, at least, after the jaundice has disappeared, before starting anti-TB treatment in those patients. For patients in who have renal impairment, don't just look at the serum creatinine levels, but also look at the creatinine clearance, which is calculated using Cockcroft-Gault formula. You can look at this formula, which is at the bottom of the slide, and calculate. But I guess most of you are using applications which are like Android applications to calculate creatinine clearance. So every ART medical officer, I think it is advisable to have an application to calculate creatinine clearance on their phone, and you can use any of that. And you need patient's age, weight in kg, and serum creatinine levels. And these are like major toxicities and advice for reintroduction. There are some toxicities where you can reintroduce ART, like what we saw just now, hepatotoxicity. If the enzymes are have returned to more than 2 times upper limit of normal, like SGOT, SGPT, or ALT or AST, if there are like 40 is normal, if they are below 80, then I think you can reintroduce. But there are some medications which or there are some adverse drug reaction which are so very serious and where you cannot reintroduce anti-TB drugs, like ototoxicity, even like ocular toxicity can be because of ethambutol, where it is again not recommended to reintroduce. Again, like immune thrombocytopenia, severe toxic epidermal necrolysis, or severe skin reactions. Then aplastic anemia, can happen because of isoniazid acid, where it is not recommended to reintroduce INH. Ototoxicity because of aminoglycoside, so it can cause permanent damages. So you need to be careful in while using these drugs, where if there are serious toxicities, it is advised to not to reinitiate ART. But if you are reintroducing, for example, in case of hepatotoxicity, on day 1 you give a smaller dose, and if there are no aggravation of toxicity, then you can give full dose on day 2 and day 3. Then you continue the first drug. On the 4th day, you add rifampicin in a smaller dose. 5th day, you continue INH. You increase the dose to full dose of rifampicin. And 6th day, you give full dose INH and rifampicin. Likewise, you add paracetamide and ethambutol also. And most of the patients, they do good if you reintroduce after 2 weeks of disappearance of jaundice in those patients, if they have initial drug-induced hepatotoxicity. So after they complete the treatment, these are the, again, programmatic definitions of outcome, which are very important to close any case of HIV-TB co-infection which you are having at your ART center. We say the patient as cured of TB. Again, this is programmatic definition. One can argue about cure in a different way, but we won't go in depth of that. So if the patient is microbiologically confirmed TB case in the beginning and now smear is negative, then after completion of 6 months of anti-TB treatment, at least, then the patient is labeled as cured of TB. Treatment completed, patient was treated with full course of anti-TB treatment, and towards the end, if we have not done the follow-up smear, or if we cannot do it, or if it is not available, then it is called as treatment completed. And treatment success, patient either cured or treatment completed are counted as success, but it is an indicator and not an outcome as such. Again, these are programmatic definitions. Failure, patient who was positive by smear or culture at the end of treatment is called failure to respond. This term is used for pediatric TB case who have microbiological conversion to negative status, or fail to respond clinically or deteriorates after 12 weeks. Loss to follow, patient who interrupt treatment for 1 month or more is called as loss to follow up. Not evaluated, patient whom no treatment outcome is assigned, or the earlier transfer outs are where we don't know what happened to the patient, is called as not evaluated. Treatment changed, if the patient who is on first line and switch to drug-resistant TB treatment called as treatment change, and patient who die of any cause during the TB care is called as died during anti-TB treatment. So HIV-TB co-infected patients, timing of ART initiation is one thing which has changed over a period of time. So all patients should be initiated ART within 2 weeks of initiation of TB treatment. So when you have HIV-TB co-infected patient, the principle is to start anti-TB treatment first, stabilize the patient, see if the patient has any side effects on anti-TB drugs or not, and whatever is happening. And within 2 weeks' time, you should initiate those patients on ART, because it is very beneficial for treatment of TB as well as for prevention of other opportunistic infections. Only caveat here is in case of TB meningitis, because in TB meningitis, if the patient has TB meningitis, the recommendations is to delay initiation of ART for at least 4 weeks after the TB treatment for TB meningitis is initiated. So you can give steroids in these patients to reduce the inflammation. Because if you start ART early in this patient, there is high chances of morbidity and mortality. And that is why the treatment is delayed, mainly due to immune reconstitution inflammatory syndrome, which sometimes becomes difficult to manage. And then as far as regimen goes, TLD, tenofovir, lamivudine, and dolutegravir is most preferred first-line treatment regimen. I'll not go and read this entire table. It looks like too wordy, but I think it's important to remember the basic principle, and then you'll be able to create the appropriate formulation. Remember that tenofovir is given to all patients because it comes in the dose of 300 milligram in our fixed dose combinations. So it is given to the patients who weigh more than 30 kg. If the weight is less than 30 kg, you cannot give tenofovir. And then that is why you will see in the first row that if weight is more than 30 kg, you can safely give TLD. But if the patient is on dolutegravir based, rifampicin based anti-TB treatment, you have to give an additional additional dose of DTG at the bedtime. So you'll give TLD, for example, in the morning, which has dolutegravir 50 mg, but you will give additional dose of 50 mg of dolutegravir in the evening. Or the other way, if you're giving DTG at the bedtime, you give additional dose of dolutegravir in the morning. And patient weight is less than 30 kg, then you cannot give, obviously, tenofovir. And as a substitution of tenofovir, there is abacavir, which is available. That is why you give this combination of abacavir, lamivudine, and dolutegravir. And same goes with additional dose of dolutegravir if patient is on rifampicin-based anti-TB drugs. And you also have to see if the patient is having renal toxicity, then you have to be careful about giving lamivudine, especially if the creatinine clearance is less than 30. If more than 30, it is fine. You have to be carefully see it. But if less than that, you will have to titrate the dosages of ART based on. There is a table which you can refer to later. Based on that, you decide the dosage of ART. If the patient is of childbearing potential, so there are some studies which had come in recent past, which had indicated some concerns of neural tube defect due to dolutegravir. But increasingly, there is more evidence to say that dolutegravir is safer in all types of patients. But if they, for some reason, if they do not wish to take dolutegravir, then you can still give TLE, that is efavirenz-based treatment in those patients. And if efavirenz is also contraindicated, because you know that efavirenz cannot be given if the patient has HIV-2, HIV-1 and 2 co-infection, in those patients, if efavirenz is also contraindicated or not of any use, you can use protease inhibitors. But if you are using protease inhibitors, then again, the The problem is because it interacts with rifampicin. Either you can give rifabutin if it is available. If not available, then it again becomes further complicated. Make all possible efforts to make rifabutin available. If no, then the answer is to give super boosting of ritonavir in those cases, which means that you give equal concentration of lopinavir along with ritonavir, which is really difficult. So I think for such cases, you need to take case-based decisions at your center after discussing with program managers and also with your head of the department. For NRTI, there is no problem at all. So if the patient is already on ART, which is zidovudine based or maybe like tenofovir or abacavir based, then we'll have to continue the same ART. Only thing is that for dolutegravir, because we are giving with rifampicin, we give an additional dose of 50 milligram as long as the patient is on rifampicin. Once the patient finishes 6 months, after 15 days, we stop with this additional dose of dolutegravir. Why for 15 days is because, again, that in hepatic induction or the of cytochrome P450 enzyme induction system, it takes some time to get normalized. And after finishing 6 months, we again wait for further 2 weeks after stopping rifampicin. Then we make DTG as single or OD dose. And if the patient is on efavirenz, again, no change is required. For PI based, like I said, this is again repetition of the same thing what we had discussed. But in principle, just remember this thing that if you are giving along with dolutegravir and PI together, you will need to give 50 milligram of additional dose of dolutegravir, and if possible, give rifabutin based anti-TB treatment. But if you have to give rifampicin based anti-TB treatment, you'll have to do super boosting of PI, which is very difficult in adult patients. So you'll have to discuss these cases specifically along with your program managers and also your faculty. Now coming to drug-resistant TB, which I briefly just mentioned in the beginning. Mono drug resistance means having resistance to one anti-TB drug. Isoniazid drug resistance is resistance to INH. Rifampicin resistance obviously means resistance to rifampicin. And polydrug resistance to more than one anti-TB drug other than both INH and rifampicin, because I said if there is a resistance to INH and rifampicin, it is called as multi-drug resistance, with or without resistance to any other drugs. Then pre-XDR is another term which recently people started using, that patients who have this MDR-TB and along with that resistance to any of the fluoroquinolone, like Leoflox, for example. Then XDR is another term which is used, which means resistance to INH rifampicin, which is MDR, and also resistance to any fluoroquinolone like Leoflox or Moxiflox, or any at least one additional group A drug presently to either bedaquiline or linezolid, so or both. So at least one group A drug. So I'll show you the group of the drugs. So group A has bedaquiline and linezolid. If there are both or at least one drug resistance is there along with fluoroquinolone, along with MDR-TB, it is called as XDR-TB. So you have to be very careful while saying these terms because every term has a specific definition for it, and accordingly patients are categorized and given the treatment. So these are like grouping. In group A, we have Leoflox, Moxiflox, which are fluoroquinolones, and then bedaquiline and linezolid, which are considered to be newer anti-TB drugs. Group B, we have clofazimine, cycloserine, and perizidone. I've never used this. And group C, there are like so many drugs which are again very old drugs. We are using them for like so many years now, and it also includes meropenem, imipenem, and which are commonly used as antibiotics in especially those ICU patients. So we have to be careful while using them. So For the side effects, and now each drug may have a different side effect, but I think it's important to remember the common ones. For example, in levofloxacin, seizure, headache, bedaquiline can have QTC prolongation, linzolid peripheral neuropathy. So whenever patient comes with like mix of side effects or toxicities, look at the medications, check these tables, which drug may be responsible for those side effects or toxicities, and remember at least those common side effects of at least one or two major side effects of each of the drug. Like clofazimine, reddish discoloration of the skin, it is very unique to that specific drug. In group C, again, delamanid QTC prolongation, amikacin, like I said, aminoglycoside will have renal toxicities, for example, nephrotoxicity, and also ototoxicity, like hearing loss or so we need to be, again, careful while using these drugs, and when patient has any of them, we'll have to immediately take action accordingly. So this is about management of drug resistance TB. I know this looks very a busy flowchart. It is actually a busy flowchart, but if we try to understand that logically, it is not that difficult. So patient who are presumptive TB cases, we do CBNAT. Like for symptom positive, we do CBNAT. If CBNAT is positive, which is if we detect Mycobacterium tuberculosis along with rifampicin resistance, like we said in some slides before, we send these patients to DRTB center to rule out further resistance to INH or other anti-TB drugs. They do first-line LPA and second-line LPA, and if they detect no additional resistance or INH resistance with only CATG or INHA mutation, not both, just one mutation. If there is no additional mutation identified, then they give these patients shorter oral bedaquiline containing MDR-TB regimen. But along with rifampicin, if they identify resistance to INH with both mutation present, along with other resistant to other anti-TB drugs, then they give longer XDR-TB regimen. So, and additional resistance or intolerance or non-availability, all these patients also are considered differently in MDR-TB centers. But if these patients are sensitive to anti-TB drugs in the first CBNAT itself, then we start with 4-drug treatment in these patients, and along with that, we send first-line LPA. And if first-line LPA is negative, which means patient is sensitive to INH, we continue with the first-line treatment. If first-line LPA is showing resistance to INH, then we consider that patient as mono drug-resistant TB. If there are resistance to other anti-TB drug, then it is called as polydrug-resistant TB. And these patients are given treatment according to that resistance profile. Just to make it simple, at ART center, we just need to see if in the initial phase, when we do CBNAT, if there is resistance to rifampicin or not. If yes, then send to DRTB center, and they decide all these things at DRTB center itself. This is about the shorter and longer or injectable MDR-TB treatment. So this is where in the shorter injectable containing, this is where we use aminoglycoside. Otherwise, we don't usually use. And in longer oral MDR or XDR treatment regimen, we use the bedaquiline, linzolid, clofazimine, and based on the combination, we decide and picking from the table which has all the 3 category of drugs. This is important for the ART medical officer to know that these combinations are there and they have these side effects, because even if they are initiated on anti-TB treatment at the MDR-TB facilities, patients do come to the ART center every month and they might show these side effects. And as an ART medical officer, you are in a good position to identify that which ART or anti-TB drug is responsible for some of the other side effects. And then you can take actions accordingly, because otherwise that might be missed in the when the patient is not going regularly to the other unit. Okay, so this is what I already said in the previous slide. If there is a rifampicin resistance identified on the first TB NAT, this is what they do in the DRTB center, and they decide if the patient has to be given shorter oral or longer oral or injectable second line anti-TB drugs. So again, all these patients who are having drug resistance TB, they are followed very closely in the TB program, and the programmatic definitions are assigned once the treatment is complete. Patients on bedaquiline and delamanid, dolutegravir-based treatment should be the ART treatment of the choice, and if the PLHIV are already on NRT and DTG-based treatment, same is continued. If they are on NNRTI-based treatment, then additional dose of DTG is given. And if they are on PI-based and third-line treatment, then SACEP decides that how the and they should actually coordinate with the DRTB center to decide the combinations and also dosages. So for delamanid, no dose adjustment is required with tenofovir, efavirenz, and lopinavir, ritonavir, and concurrent use of efavirenz may not require dose adjustment also. For pediatric TB cases, there will be very few cases, I guess, in these days you might be seeing in your centers, but whenever you see, please do care for them very seriously, or have a close follow-up in these patients, because they are very vulnerable anyhow. So even if the cases are less, we have to be very careful while treating pediatric patients. You may not need pediatrician at all steps. These patients can be managed at ART center itself, but whenever you need not be shy from like taking help from pediatricians. So the presentation is usually type of primary progressive, which means initial primary tuberculosis and which progresses further. In adults, usually we get reactivation of old TB infections, but in pediatric patient is usually primary progressive TB. Extrapulmonary TB is again common. There are diagnostic difficulties, multi-drug resistances can happen. Case fatality is again higher in such patients. Clinical features are again what we saw in the beginning. There are from the 4-symptom complex, these two things are different, like failure to thrive and weight loss or poor weight gain, and or history of like contact with TB case. And in extrapulmonary TB, the signs and symptoms depends on the site which is involved outside the lungs. This is again diagnostic algorithm, which is logically similar to what we saw, but the basic principle is if the patient is symptomatic or having any of the 4 symptom from the 4-symptom complex as a positive, then patient is considered as presumptive TB case, and that patient has to be further investigated for presence of active TB disease. Then we do CBNAT chest X-ray in these patients to identify whether there is a TB or not. If there is TB, we treat with full course. And if there is a presumptive extrapulmonary TB, again, CBNAT is helpful if you can get the sample and test and send for testing. And if not, then in some situations, we rely on cytohistopathological examination. And in some situation, we just depend on the radiological finding like X-ray, USG, or CT scan. And based on that, we decide if the patient has extrapulmonary TB or not. The dosages, again, these are dosages for pediatric cases. They are different from adult. And this is the chart like what we saw in the adult. This is, even though you might see overlapping weight bands, but just remember that those who are less than 18 years of age, you will apply this chart. If they are more than 18 years of age, apply the adult chart for calculating doses in those patients. Now, for ART, it's like in adults, we were worried about tenofovir if it is less than 30 or more than 30 kg weight. In pediatric, mostly it is dolutegravir because less than 20 kg or below 6 years of age. Here, we cannot give dolutegravir because the strength which we have is 50 milligram strength, and that is why in such cases we give a bacavir-based treatment. But if it is between 20 to 30 or above 20, above 6 years of age, you can give dolutegravir. But above 30 kg of weight, you cannot give, or if the weight is below 30 kg, you cannot give tenofovir. So that is why above 30 kg and above 10 years of age, you give tenofovir based treatment. So this is because the combinations we have in the strength of 300 milligram of tenofovir, 50 milligram of dolutegravir, 600 milligram of abacavir, and we try to manage with those strengths. That is why these age and weight cutoffs are really important to decide the regimen. It is not that tenofovir can never be given if the weight is less than 30 kg. It can be, but we have 300 milligram in fixed dose combination, so we cannot cut or distribute that in different dose schedules. We don't have other. It is not contraindicated in pediatric, but the issue is the combinations what we have. So that is why, based on this weight and age, you decide which combination is to be given in those pediatric patients. And again, principle of dolutegravir is same. If the patient is on rifampicin-based treatment, give additional dose of DTG, stop additional dose after 2 weeks of completion of TB treatment. Again, diagnosis of treatment of, I think this is very similar to what we have discussed in adult. I'll not repeat what we have already discussed. And most of it also happens in DRTB center. So once you suspect drug resistance in pediatric case, refer those patients to DRTB center. They will take care of the further investigations. So if pediatric patient is in close contact with MDR-TB case, then we have to suspect MDR-TB in those patients, even though we may end up starting with first-line anti-TB treatment in those patients. But these patients will require close follow-up, especially if there is any situation like this, close contact with MDR-TB case, or a patient who has died of MDR-TB in the family, failed TB treatment, non-responsive. So because they might acquire TB infection from someone close in the family, it is important to know what kind of TB that patient is having, and also what kind of treatment outcome that patient is having. So for treatment of MDR, again, I don't think we need to go in any details here. If it is oral bedaquiline containing regimen, it is 9 to 11 months of duration. If it is a shorter oral bedaquiline containing, it can be like for 6 months. And all these combinations we decide based on the type of patient we have. So based on type of patient, we pick and choose these drugs from the 3 categories what we saw. Protease inhibitors, again, the problem is with rifampicin. And if we are again able to use rifabutin, there is no problem as such. But if we are using rifampicin-based treatment, we have to be careful, especially while using protease inhibitors and while giving dolutegravir. This is again the similar thing. Pregnant lactating women, usually there is no problem as such. The first-line anti-TB drugs are safe in pregnancy and lactation. Among the second line, in injectable, they are contraindicated because they can cause serious 8th nerve palsy and auditory issues in children. Fluoroquinolone in pregnancy also can affect cartilage development. Ethionamide contraindicated in first 32 weeks of pregnancy. Bedaquiline and delamanid, thankfully, are safe in pregnancy, and because they are very important these days. So shorter bedaquiline containing regimen cannot be administered during pregnancy. And in oral because of, again, the other drug combinations. In renal impairment, ethambutol and some other drugs also will have some issues. And as far as ART is concerned, lamivudine and tenofovir we need to be careful of, and that is why we need to calculate the creatinine clearance, and based on that we need to take a decision regarding the dosage. IRIS is immune reconstitution inflammatory syndrome, which is nothing but when you treat the patients with ART, it will boost up the immunity, and that boosted up immunity may respond very aggressively to the existing infection or the hidden infection. In that process, clinically patient deteriorates. It is very similar to paradoxical reaction, and we need to see at some stage we may have to stop ART, but that is in very serious stage. But most of the immune reconstitution syndrome, if it is self-containing, even if there is some deterioration clinically, you can still continue ART and anti-TB treatment in those patients. We may have to give anti-inflammatories, or we sometimes may have to give steroids in patients. We have to be vigilant about immune reconstitution syndrome in all patients who are treated with who are started with ATT along with ART. So yeah, so these are like principles we need to do. Airborne infection control prevention practices at the ART center, start INH prophylaxis in whoever is eligible for, do for symptom screening in all patients. So these are, and also if the patient is symptomatic having cough, try to give those patients masks. Every patient need not wear mask, and those who are symptomatic having cough especially need to be given mask. And if they are microbiologically positive, proved case, diagnosed case, again they can use mask. It is not necessary for others to wear mask at the ART center for this reason. For prevention of TB. Of course, COVID has changed things a lot. So for that, you can follow the local guidelines. And lastly, about airborne infection control, it is easy to say, but difficult to implement sometimes because of many issues which are related to administrative controls or managerial processes at the RT centers. So we need to do whatever we can do. So take simple steps at the RT center, have table fans, for example, have windows open, don't block the airflow, and also do some local adjustments within the seating arrangements, which may help you to have this free flow of air. You can use mask on, especially give mask, and again using like triple layered surgical mask. You can give that to patients who are symptomatic, but as a medical officer you can use an N95 mask. So these are for different reasons why we are doing this, because when patients cough, the droplets are bigger in size, and surgical masks are good for, or may be good enough for them. But once it becomes an aerosol, and if it is in the air, then the other are exposed to the risk. And that is why the medical officer can use N95 mask. Otherwise, triple layer surgical masks are good enough for patients who are symptomatic. I know this was a bit faster because I just assumed that many of you have seen this before, and also we have discussed this many a times. I've not seen if there are any questions, but if there are questions, I'll be happy to answer. Thank you.
Thank you, sir. There's one question in the chat box. What shall be the dosage of DTG in cases of MDR-TB on bedaquiline?
MDR-TB on bedaquiline, again, if rifampicin obviously is not in this, then the DTG dose will be OD. Only thing we give it BD if the patient is on rifampicin-based treatment.
Participants can unmute their mic and ask questions, or they can even type in the chat box. Any questions from the participants?
I know this has been repeated so many times, this session and HIV-TB co-infection. Maybe since the day you joined the ART center, you have heard like hundreds of sessions like this. So I think one of the advantages of having the text heavy slide is you can refer to that whenever you want. So if you are okay, you can keep it on your phone, or if you're okay, you can take printouts and keep at your center. So whenever you want, you can refer to these slides. And if you have any more questions, you can always email us, I guess. Thank you.
I don't think there are any questions. Can we quickly run the feedback form, please? The feedback form is now visible on your screen. Participants are requested to please answer all the 4 questions.
Feedback form is not visible, ma'am.
It is launched, it's working.
Any questions from the participants?
Ma'am, when shall be the next lecture?
6th of February, that's Monday. The timing will be 12 to 1 p.m.
12 to 1.
Yes.
And topic, ma'am?
It's post-exposure prophylaxis for HIV.
Fine. Thank you, ma'am.
Thank you.
Feedback form is not visible, ma'am.
So there must be some internet issue, otherwise the feedback poll is visible. Thank you, sir, for
Anyway,
facilitating. Thank you, sir. Thank you, Anwar, sir, for facilitating this session. Thank you to all the participants for patient listening. So can we conclude the session now?
Yeah, sure. Thank you very much.
Thank you, sir.